Okay, thanks, Dr. Sender, and thanks, everybody, for the opportunity to speak to you today. Dr. Sender gave me a challenging task. We go long ways back, and so I think he likes to challenge me. I have far more experience with blinatumomab, but I also have experience with inotuzumab, and our institution also is doing CAR T cells, although with kite in the non-Hodgkin's lymphoma setting. So I think we have experience to see all of these patients. And I thank Pfizer for the opportunity to present their slide deck, which contains also a lot of information about the basic biology behind Inotuzumab Ozogamicin. The idea, of course, is to develop a monoclonal antibody with a reactive payload. And first, I want to talk to you a little bit about CD22, because the other immunomodulatory therapies that have been presented are focused on CD19, and inotuzumab instead is directed against CD22. And this is a very different B-cell specific adhesion molecule. It's preferentially expressed on mature B lymphocytes, and it regulates somehow in the black box of the B cell signal transduction from the surface into the interior of the B cell. It's an interesting molecule. It's a good molecule to target. It's expressed on 60 to 90% of B cell malignancies, and you can see that in acute lymphoblastic leukemia, CD22 expression is extremely common and present in over 90% of leukemia blasts. It is not expressed on hematopoietic progenitor cells or on non-lymphoid hematopoietic cells or on cells outside the hematopoietic system. And its expression is lost with differentiation of the B cell and its normal ontogeny. So based on testing, CD22 is one of the better internalizing molecules among several B cell specific, lineage specific surface antigens. And I sure hope that somebody asks a question about any of these immunomodulatory agents. Can they really compete with allogeneic T cells in a stem cell transplant where there are a whole bunch of targets against which the allogeneic cell can act? What's also nice about CD22 is it's not shed into the extracellular environment. And so the idea here is a pretty simple one, simple for me not having to produce it, but a little more complicated for the chemist who produce it, and that is a humanized anti-CD22 monoclonal antibody with a special linker, hopefully a better linker than the one we know about in gemtuzumab, to a natural toxin. Many parts of a pine cone are edible. I wouldn't want to necessarily eat Calicheamicin. That is a very toxic DNA intercalating chemical, which is the active payload of the monoclonal antibody. And obviously, this antigen-antibody complex is intercalated and internalized upon binding to its CD22 target, where Calicheamicin is released. And Calicheamicin is a very, very toxic, potent cytotoxic agent that, in some ways, like anthracycline, binds to DNA in the minor groove, induces double-stranded DNA breaks, and induces cellular apoptosis. So preclinical studies of ALL indicated that this was a very selective monoclonal antibody attached to a payload. And here you can see in a variety of cell lines that inotuzumab has tremendous growth inhibitory effects on cells that express the CD22 surface antigen, as opposed to Calicheamicin alone or gemtuzumab, which doesn't hit that target at all. And again, the focus of the targeted monoclonal antibody with payload is against B-cell ALL and lymphoid cells that express CD22 as the antigen. And you can take a look here at a tumor growth in SCID mice who are engrafted with a human ALL cell line that inotuzumab profoundly suppresses the growth of these cells, as opposed to other drugs such as gemtuzumab hitting a completely different target, CD33, or the Calicheamicin molecule alone, unconjugated. And so there is, with this molecule, conferred a great deal of specificity by the CD22 monoclonal antibody. Here you can look at the effect of inotuzumab on survival of mice with disseminated ALL from an ALL cell line, and you can see that inotuzumab at 2 different doses has a suppressive effect on the engraftment and the lethality of the engrafted ALL tumor cells. What about treatment in humans? Well, an initial trial of weekly outpatient, I would like to emphasize, because this drug can be delivered in the outpatient setting, inotuzumab in adult patients with relapsed or refractory CD22 expressing acute lymphoblastic leukemia was done to evaluate its safety and its efficacy. And a secondary endpoint, of course, was to look at the remission rate and overall survival. Another question that I hope somebody asks when we get together as a panel is, how do you ever get regulatory approval if you have the option then to go off to allogeneic transplant, which muddies all waters in interpreting overall survival? But I'm just kind of feeding some questions to the audience to keep you engaged, because I know many of you would like to be eating lunch. As would I, to be honest. And, of course, the role in minimal residual disease and in PK. The eligibility were kind of self-evident. Patients had to have relapsed or refractory ALL that expressed CD22, and so, that our hematopathologists did not, prior to this study, typically assess, but they do now, fortunately. Philadelphia chromosome-positive ALL was allowed into this trial, which is distinct from some of the other trials that you've heard today, as long as there was demonstration of lack of response or failure or progression after tyrosine kinase inhibitor. This was definitely a trial for adults, but the performance status eligibility was quite broad, including performance status ECOG 3. Patients had to have adequate hepatic and renal function and lymphoblasts that were fewer than 25,000 per microliter. No prior allogeneic transplant was allowed, and that's something we can talk about. And no prior therapy with monoclonal antibody was allowed for entry onto this trial. The trial consisted of weekly dosing of Inotuzumab Ozogamicin, in first a phase 1 dose finding, and then in a part 2 a dose escalation cohort. And this is basically a diagram looking at the dose levels, -2, -1, and then the progressive dose increase with the weekly dosing with bone marrow aspirate and biopsy performed for disease assessment, typically at day 21 or day 28. And this is the total dose achieved during a 3-dose cycle in a 28-day period. I always tell patients that we are addicted, I think, to Jewish calendar months, lunar months of 28 days, and we've gotten rid of all of this Roman pagan stuff of 30 or 31 days in a month. So this is basically the characteristics of the patient, very similar to what you've seen with the other studies. These patients had advanced disease. Some of them were salvaged really after multiple prior lines of therapy. This is definitely a trial in adults without too many adolescent young adults, although you see a little bit distributed here in the different age cohorts. Patients generally had complex cytogenetics. There was a little bit of Philadelphia chromosome-positive expression. I won't look at this small group here at the lowest dose, but in the bigger cohort, you see that there is some representation of Philadelphia chromosome-positive ALL, as well as some other adverse prognostic ALL by cytogenetics. Patients had quite a bit of refractoriness to prior therapy. You see that the distribution of refractoriness to the last therapy was present in a third of the patients. Of course, CD22 expression had to be present. There was approximately a fifth of patients who had had prior allogeneic transplant. Median white count at presentation was again controlled and constrained by the eligibility criteria of the trial. However, 2/3 of the patients had blasts at baseline. You can see the number of cycles that were administered. A number of patients received greater than 2 cycles, and the median dose and the dose range, the cumulative dose, was considerably higher than what had been anticipated, and 2/3 of the patients went on to stem cell transplant after 1 to 2 cycles of drug. Dose delays did occur. They were not terribly frequent. Dose reductions were notably infrequent in this trial. Non-hematologic toxicities, again in this trial, considering the kind of patients that were entered, consisted of ALT and AST elevations at the higher dose. That's something to pay attention to. Some increase in GGT as a more sensitive marker of hepatocellular injury, not too much increase in alkaline phosphatase. Interestingly, the induction of neutropenia and thrombocytopenia leading to dose reductions was very uncommon, and it makes me think of Dan Dewar's frequently quoted remark, or it should be frequently quoted, one does not need to achieve neutropenia to cure ALL. And so I repeat Dr. Dewar's remark here as well. Treatment-related non-hepatic AEs, again, you can see a little bit. They probably came in with myelosuppression, not much in the way of gastrointestinal toxicity or anorexia, not even much in the way of anemia that is attributable to the drug. But the hepatic AEs are the ones that I think all of us want to pay attention to, because those of us who've had experience with the gemtuzumab know that that, of course, is the fatal flaw of Calicheamicin when attached to an anti-CD33 monoclonal antibody. And looking at all the patients in this dose escalation cohort, you do see that there is some degree of hepatic signal, not much in the way of hyperbilirubinemia, not much in the way of hepatic veno-occlusive disease, but biochemical abnormalities that are attributable to dosing of the drug. And here you can see the concentration that is achieved by inotuzumab at the end of response. And of course, in those who achieved a complete remission, it seemed that the concentration achieved was greater than in those who did not achieve a remission, suggesting that perhaps the expression of the CD22 marker has something to do with retention, perhaps, of the molecule. The best overall responses are written here, and again, for the entire group, about 2/3 of the patients achieved either a complete remission or complete remission with incomplete hematologic recovery, and the median time to achieve complete remission was there in that lunar or Jewish month of about 28 or 29 days, with the typical characteristics of complete remission that are described here. Minimal residual disease was achieved in the patients who achieved complete remission. Generally, again, similar to the other immunotherapeutics that you've heard about today, achieved a state of minimal residual disease with a time course to achieving minimal residual disease very close to what was achieved in terms of histologic complete remission. So again, subsequent stem cell transplant was generally the process for investigators who had patients on this trial. And so for those who achieved complete remission, about 1/3 of them underwent allogeneic transplant. And again, it's an important concept, so even if you're in an institution that's geared toward doing a salvage allogeneic transplant in an advanced stage of remission, the likelihood that you're going to get there is only 30, or in the blinatumomab experience, 40%. And so if survival is your outcome, as your regulatory outcome, but only 30 to 40% of your patients with advanced remission get allotransplant, the supposed treatment that induces long-term survival, and Steve is nodding his head because maybe it isn't, then how do you ever assess survival impact of a drug or a therapy? So anyhow, about 1/3 of these patients went on to allo. The median time to getting to allo was pretty fast, and 3 patients died owing to sepsis or septic shock after the allogeneic transplant. And so the dose that was determined in the dose-finding study was 1.8 milligram per meter squared per cycle. The drug had an acceptable safety profile with some biochemical signal for hepatic AEs. The single agent had encouraging activity in this group of highly resistant disease, and the preliminary effects appear to be related to the inotuzumab concentration area under the curve, and thus, of course, this has led to phase 2 trials and currently a phase 3 randomized trial. Now, Dr. Stock is in the audience. She's one of the people who did a lot of work on the initial phase 1 trial of inotuzumab, and want to express thanks to her and the other investigators and their patients who participated in the trial. We participated with them in the phase 2, and now we're participating in the phase 3 trial. And again, this will be a very challenging trial to assess, not merely to accrue to, but also to assess. And the trial basically follows much of what was learned in the phase 1/2 trial. Again, relapsed refractory CD22 expressing ALL with an anticipated number of 325 patients randomized in a 1-to-1 fashion, unlike the blinatumomab, which is a 2-to-1 randomization, to weekly inotuzumab. Again, this is feasible as an outpatient schedule with day 1 of 0.8 per meter squared and days 8 and 15.5, so that total dose can be achieved of somewhere over 1 milligram per meter squared. And for patients who achieve complete remission, they can go on to receive a consolidative treatment in cycles 2 to 6 versus a bunch of investigator choices, all of which I think you're very well experienced. Allogeneic transplant is encouraged if CR is achieved, and patients are followed for progression as well as 2 to 5 year survival and transplant-related toxicities for those who undergo allogeneic transplant. The primary objectives, of course, are to compare complete remission rates in patients randomized 1-to-1 inotuzumab versus the dealer's choice of active comparators. Fortunately, this trial uses overall survival as a secondary objective. I say that fortunately because of all the hazards in interpreting overall survival when allotransplant is a potential option. Also, duration of response, progression-free survival, and the rate of usage of stem cell transplant is also a secondary thing to be evaluated. We're all interested in the safety and tolerability, particularly the impact of prior Calicheamicin exposure on later hepatic events after the allogeneic transplant, and then, of course, looking at population PKs and quality of life parameters. And so that trial is currently accruing. We're enthusiastically participating in it, as well as the blinatumomab trial, and now I think you want us all to go up to the table to take questions. Thanks.